It's always a pleasure to be back and honored to be with Dr. Ravindra Mohan, Dr. Nitin, Dr. Haider, and good to see youngsters coming up as well. Thanks to Dr. Lalit Verma also for his kind invitation. So in the 10 minutes or so that I'm given, I'm going to touch a little bit about some of the newer concepts and principles of orbital reconstruction. We know there are lots of newer advances, and there was a beautiful talk earlier this morning about minimally invasive approaches. The techniques still remain the same. The principles and concepts and techniques more or less still remain the same, but there are slightly newer novel implants and approaches to orbital reconstruction as well. Technique is always complemented by technology. We'll touch a little bit about it. And finally, what we don't do enough of is the concept of quality control. Have we done a job good enough? So I'm going to touch a little bit about principles and concepts of these. Some disclaimers. So there was this book out which is launched at the APORTS meeting last year. And there's another book which is going to come out possibly in the next couple of months on basically clinical pathological correlation of orbital and ocular pathological lesions with a foreword by Mr. Jack Rootman himself. So what's new in orbital imaging? Number one, traditionally we are used to seeing films. I think there was a beautiful talk this morning about MRI and says load the film on the film viewer. We don't even do that anymore as well. Traditional orbital cuts were 3 millimeter cuts. And we used to rely a lot on 3D reconstruction of the orbits, which we practically find useless in our daily practice. The current concepts is all image DICOM data that we use on computer software. So to me, what is more important than the film itself is the CD that the patient brings along, and you should probably have an image viewer itself where you're doing real-time millimeter by millimeter analysis of axial, coronal, sagittal, as we'll show later. And finally, the data which comes on a CD or a thumb drive is what is going to be useful for your treatment planning. And if and when you're going to do navigation, you can use that as well. So these are examples of cuts I'm going to show you over here. So literally, you do a CT phase and orbits. It's not just in CT orbits itself, where you're looking at not just the orbital cavity and the orbital walls, but you're looking at the maxilla, you're looking at the frontal bone, you're looking at the coronal bone, so on and so forth. And so that way you have a complete front all the way from the nasal tip or the nasal bones all the way to the sphenoid bone and beyond as well. Likewise, you know the axial images are the true original images as well. You again start off from the lower part of the maxilla. If that's where the fracture is, it's a midfacial fracture, but as a panfacial fracture, you want to start from the mandible and literally scroll and look at the image millimeter by millimeter. And that's very useful because we oftentimes miss fractures which is beyond the orbital confines. And I've seen enough and more patients with orbital fracture repairs done where CT orbits has been done, repair of the orbital fracture has been done with implants stuck any which way they can, and a lot of other maxillary and frontal bone fractures have been missed as well. So you want to have a methodical, sequential, axial, coronal, and a sagittal on these images so that you can make a complementary decision. The second thing I'm going to touch upon a little bit about is a practical classification of orbital fractures. Traditionally, as ophthalmologists, we are taught about blower fractures, a little bit about blow-in fractures, and everything else was labeled as a complex fractures. Okay, so we came up with a practical classification where we labeled them as simple fractures, and when we submitted our manuscript initially, we were told orbital blower fractures are not simple fractures for the maxillofacial surgeon. They are nightmares and disasters actually. But to us, simple fractures are linear fractures. Blower fractures can be one wall, two wall, or more than that itself. And finally, the blow-on fractures, because these are some things that you more or less will be able to manage it single-handedly without any major issues. But where we become a part of a team is where the spectrum of complex fractures, where you have ZMC fractures, NOE fractures, which account for only about 3 to 5% of all fractures, quite rare. Because they are rare, we don't recognize them often, and we don't manage them initially. We end up with a lot of complications. Finally, the orbitofacial fractures, which is quite common, cranio-orbital fractures, roof fractures, skull base involvement as well, and finally the spectrum of a panfacial fractures. And then we came up with patient modifiers because the classical classification does not tell you about threshold for intervention, timing of intervention, should you go in or not, what kind of implants you put in. So we came up with the ABCDEFG mnemonic, where the age, whether the child is a 3-year-old child or a 60-year-old woman, the same fracture is managed very differently. The threshold to intervene is very differently. The timing is different as well. Laterality, whether it's a bilateral or unilateral fractures, that has implications on how the approaches are going to be, how long the surgery is going to be, so on and so forth. The complexity, as we talked about, the simple was orbital fractures was a complex fracture, because that kind of tells you whom you're going to work with or who you're going to call to manage your orbit along with the rest of the face or the cranial bones itself. And the degree of displacement, again, is never usually talked about because you know very well minimally displaced fractures usually may not need to be intervened. But be careful because very minimally or linear fractures are also the trapdoor fractures. So just because a fracture is very small doesn't mean that the clinical consequence is negligible. You have to still look at the functional component as well. Entrapment is a clinical sign, not a radiological sign, and that again tells you the threshold to intervene and timing to intervene, whether it's an associated foreign body or not. And finally, but not the least important, but probably very important, is the globe involvement, whether it's an open globe injury, closed globe injury, or traumatic optic neuropathy, because this has huge implications, both medical and medico-legal as well. So here's examples of patients where if you sufficient just looking at the orbit, you miss actually the fractures, and the rest of the part of the face itself is a ZMC fracture, which you want to miss as well, and that kind of degree of displacement tells you the threshold intervention. Here's another patient who is also quote-unquote referred for an orbital fracture, but if you look at all the fractured bones, everything from the calvarial vault to the walls of the orbit to the midface, and even the mandible, which is the lower face itself. So this is a panfacial fracture, which again, you're not going to be just doing an orbital surgery alone. You need to work with the complex craniomaxillofacial team to fix it. So this becomes a panfacial fracture, which requires a multidisciplinary approach. The third thing I'm going to touch upon a little bit is about anatomical considerations. As residents and fellows, we are taught to memorize the bones of the orbit. Invariably, we forget the seventh bone, which is the palatine bone, which is very important. That's a posterior ledge. Then we taught about the fissures, canals, and so forth. But when you start doing trauma and fractures, some anatomical landmarks are very important. The frontozygomatic suture and the zygomaticosphenoid suture. So look at the principles of reconstruction. If you don't get the rim right, it's like the picture frame of a picture. The picture itself is never going to be right. So you have to know the anatomy of the frontozygomatic suture and the zygomaticosphenoid suture, so when you reduce these fractures, they are in perfect alignment. So the other important thing from us, internal orbital structures, is the concept of the posterior ledge and the medial wall, along the medial wall and the floor. And that's the posterior ledge we're talking about over here. That's the sinus over here. That bony edge over here is a posterior ledge. And this is something which is poorly addressed both by dissection and implant placement, and hence we see a lot of complications. So this is from one of the cadaveric courses where we're talking about the orbit itself, okay? And the video is a little bit twisted over there. So you're looking at the cavity, the sinus cavity itself. That's the orbital strut. And the way you identify the orbital strut, I think because we talked about this, about identifying the orbital strut intraoperatively, is that's the posterior ledge. Nice, tough, strong bone, very hard to break, but every once in a while is also shattered itself. So you get into the sinus, go along the posterior wall of the maxilla, and walk your way up along the posterior wall of maxilla, and finally your free air is going to hit against the structure. That bony structure is a posterior ledge, and that's a good guide to tell you whether you really got into the posterior aspect of the discussion. So in the interest of time, I'll just keep moving on. Yeah. The fourth advance, or in terms of orbital implants itself, we have moved away from the traditional single sheet implants to more biological or anatomical implants itself. We're moving away more from permanent implants to bioresorbable implants, and now we're coming to the area of customized implants itself. So these implants, anatomical prefabricated implants, which have an inbuilt S-shaped contour to it as well, can be further customized to the patient based on the principle of the angle of the inframedial orbital strut. So basically what we measure is the angle between the floor and the medial wall on the contralateral side. And believe it or not, despite the textbooks that are written by Jeff Nerad and Jack Rootman and so on and so forth, they don't touch upon it. Everybody's angle is very different. So if you have a unilateral displaced fracture, we measure the contralateral angle, anterior, mid, and posterior, pre-bend these anatomical implants, and then place it inside the orbit itself. Examples are symmetrical, accurate anatomical reconstructions shown over here as well. You can see the medial wall, the floor, the ledge between the medial wall and the floor, and more importantly, on the sagittal cuts, you can even account for that little bulge that you're supposed to see compared to the contralateral orbit. Remember the S-shaped contour rather than sheet implants itself, and of course, leads to patient satisfaction. So over the past 10-15 years, we've been using a lot of bioresorbable implants, polycaprolactones, polylactides, and each has its own advantages and disadvantages. We now, even for combined floor and medial wall fractures, we are now able to pre-bend a bioresorbable implant to the contour of a prefabricated plate, customized and pre-bent for the patient itself, so you can correct now floor and medial wall reconstructions bioresorbables. The current, which is once upon a time was the future, is patient-specific implants. So you're able to now design implants to defects so that when you have complex deformities like these patients who need extensive parts of the face and the orbits removed, we can pre-print these implants and then implant it in the face itself. Last thing I'm going to touch upon is the post-operative imaging. This is never done or done only in the face when you have a complication itself. And we are big believers of post-operative imaging. So if you're a cataract surgeon, do you not do post-operative refraction for your patients? Never ever, right? That's your quality control of your biometry testing. So likewise, to me, I'm a strong believer that there is a role for post-operative imaging. We don't go around imaging all the patients as well. I think the learning curve is also very important, very similar to minimally invasive surgeries. This probably you don't need to do it routinely, but I think if you're a beginning orbital surgeon, you're sticking stuff inside the orbit any which way you can. And just because the patient's doing fine, and more often than not, you don't want to know where your implant is, we don't do it. So I think for a beginning surgeon, for quality control, to know where you are, it's very important to imagine as well. As a routine, we'll probably do it in all complex fractures itself. Time out. 2 minutes. Dr. Lahane is here. Yeah, give me 2 minutes and I'll finish. Okay? And if you're starting to use new implants, because you're going through a learning curve itself, I think you need to know whether the angles that you bent is sticking in, whether you placed it on the posterior ledge is really on the posterior ledge, believe it or not. Even with navigation, I've seen implants being stuck below the posterior ledge rather than above the posterior ledge. So technology is not a replacement technique itself. And finally, when you see a patient and counsel them preoperatively, making sure you have delivered what you have promised preoperatively is very important. So what are the indications in our practice is complex orbital and orbitofacial fractures. When you're doing stage reconstructions, all 4 walls are busted. We start from the roof, then the lateral wall, then finally the floor and medial wall. When you're doing it in stages, you could do it as well. We do that as a part of all revision fractures, because especially going back in the second time, you damn well deliver rather than say, oops, there's a problem again as well. And it's now becoming a quality control, so much so that insurance companies now determine, why did you have to go back in? We are not going to cover it for the revision itself, and hence that becomes important. So here's examples of patients where the posterior ledge is over here. The implant is, as you can see, against the posterior wall of maxilla. We have to do a revision surgery, place it along the floor of the orbit itself. Likewise, a bioresorbable implant which has been placed when a previous prefabricated implant is impinging against the inferior rectus itself. So I like the good, bad, and ugly concept, and the movie as well. Keep watching it 100 times and still can watch it again. Examples of badly placed implants, the wrong implants, worsely placed implants where the implants are in the sinuses, and what you really want to chase is a good implant. So in summary, orbital and orbitofacial fractures lends itself to a lot of new advances and concepts. Principles are the same, but there are new technologies as well. Learn the concept of multidisciplinary work and multidisciplinary approaches. Adopt minimally invasive approaches like our chairperson really talked about. We are moving away from standard sheet implants to customized patient-specific implant. One size doesn't fit all. And finally, make sure you're the kind of surgeon who ensures there's good quality control. And thank you very much for your kind attention. Thanks for the invitation again.